Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Gemma Percival, a PGY3 anesthesia resident in Saskatoon, and Dr. Oksana Prokopchuk-Gauk, the Provincial Medicine Lead with the Saskatchewan Health Authority and an adult hematologist, discuss the use of albumin in the perioperative setting. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Today I'm going to be talking about intravenous albumin use and appropriateness in the perioperative setting. This is a very timely topic as there has been a recent guideline release as well as systematic review earlier this year. And I'm very, very honored to be presenting in collaboration with Dr. Oksana Prokopchuk-Gauk from Transfusion Medicine. So our learning objectives today will be first to describe the rationale for conventional use of albumin in patient care, summarize recent clinical practice guidelines and published evidence regarding albumin administration in the perioperative setting, examine current national, provincial, and local albumin utilization data. As for disclosures, I have nothing to disclose. Oksana has a few disclosures related to honorarium consulting fees and as well as other educational traffic codes, but this presentation has not received financial support from any organization. So just getting back into some basic science background, speaking of albumin. So human albumin is the most abundant circulating protein, constituting approximately 50 to 60% of total plasma proteins in healthy individuals. Albumin is synthesized exclusively by the liver, with hepatocytes releasing approximately 9 to 12 grams of albumin into the bloodstream daily. Albumin catabolism is ubiquitous and takes place at the vascular endothelium, muscle, skin, and kidneys at a daily rate that equals hepatic synthesis. Several hormones can increase the body's ability to synthesize albumin, but malnutrition, stress, medications, and aging may all decrease production. The circulatory half-life of albumin is approximately 16 to 18 hours, during which 4 to 5% of albumin exits the intravascular compartment each hour, subsequently re-entering via the lymphatic system. In healthy adults, the overall half-life of albumin ranges between 14 and 20 days. Serum albumin is lost at a rate of about 12 grams per every 500 mils of blood loss. Thus, in a setting of a hemorrhage that would require a replacement with 4 units of packed red blood cells, albumin loss would be entirely replaced by normal synthesis within approximately 3 days. Albumin is the most important modulator of fluid distribution among the different body compartments. Endogenous albumin is distributed between the intravascular and extravascular space at a ratio of 40 to 60%, where it is the most abundant protein in both compartments. Although accounting for only approximately half of the plasma protein content, albumin is responsible for generating 75% of intravascular colloid oncotic pressure. 2/3 of its oncotic properties is due to its molecular mass and high concentration in the bloodstream, while the remaining 1/3 is due to the presence of negative charges on its surface, which allows it to attack positive ions such as sodium and consequently water. And this is known as the Gibbs-Donnan effect. Beyond that, endogenous albumin serves many important functions in the human body. It binds and transports various endogenous and exogenous compounds, such as unconjugated bilirubin, fatty acids, cholesterol, bile salts, and in our case, drugs. Additionally, it functions as the most abundant circulating antioxidant, capable of scavenging both oxygen and nitrogen reactive species. Apart from its role in combating oxidative stress, albumin modulates inflammation and immune responses through various mechanisms, such as binding prostaglandin E and stimulating immune cells. Furthermore, it plays an important role in homeostasis and pH regulation. Given albumin's many functions and its synthesis is dependent on adequate daily protein intake, it is not surprising that hypoalbuminemia is a frequent finding in many acute and chronic diseases, and that hypoalbuminemia acts as an independent predictor of poor outcomes. In the postoperative period, serum albumin levels decrease precipitously by 10 to 15 grams per liter. Hypoalbuminemia is thought to be the result of suppressed synthesis by inflammatory cytokines as well as transcapiillary loss. A large study involving approximately 15,000 patients hospitalized for acute illnesses demonstrated that hypoalbuminemia at admission strongly predicted both mortality, length of stay, as well as hospital readmission. Recently, hypoalbuminemia has been identified as an independent prognostic factor for worse outcomes in patients with COVID pneumonia as well. Given the corollary to this, and that administering intravenous albumin could theoretically be beneficial to patients who are hyperalbuminic or hypotensive due to intravascular volume depletion, it was then suggested that albumin be used to counteract this. So since its introduction into medical practice during World War II to expand plasma volume in critically injured patients, exogenous human albumin products have been utilized as a therapeutic agent. Over time, albumin administration has expanded to various clinical conditions associated with hyperalbuminemia, based on the assumption that correcting it would confer clinical benefits. Despite the established prognostic significance of hypoalbuminemia, the effectiveness of exogenous albumin administration in improving outcomes, though, remains uncertain, with many indications lacking robust scientific evidence, rendering much of its therapeutic use inappropriate. Albumin is typically available in two concentrations, those being the 5 and 25%. 5% albumin is isoosmotic with plasma, and 25% albumin is hyperoncotic, and is roughly equivalent to a plasma volume of 4 to 5 times higher than infused volume. Therefore, 5% albumin is used for therapeutic plasmapheresis or conditions associated with volume defects alone, whereas 25% albumin is reserved as the product of choice in patients that have an oncotic deficit. Further to that, 500 mils of 5% albumin, which equals 25 grams of albumin, can be expected to increase your intravascular volume by about 500 mils. Whereas 100 mils of 25% albumin, which also is 25 grams, will give you a 450 mils increase in intravascular volume. And it's really important to keep this in mind, as administering 25% albumin instead of 5% in error could result in circulatory overload in some patient populations. So from a physiological perspective, the oncotic effect of albumin infusion, which is calculated to attract approximately 18 mils of water per 1 gram of albumin, would be expected to expand plasma volume more effectively than an equivalent volume of normal saline. Theoretically, this probably should be beneficial in situations where we as physicians aim to minimize volume overload by retaining fluid intravascularly and reducing third space loss. Based on its oncotic properties, intravenous albumin administration is anticipated to expand intravascular plasma by a magnitude several times greater than crystallite solutions alone. However, intensive care unit studies involving critical care patients revealed a lower than expected ratio, with approximately 1.4 liters of saline required to achieve the equivalent volume of intravascular expansion as 1 liter of human albumin product. Notably, in a trial of 321 critically ill patients requiring fluid resuscitation, The cumulative volumes of resuscitation fluid was reduced by 600 mils over 48 hours through the use of 20% albumin compared to 4 to 5% albumin fluids, suggesting that volume effects are very much dependent on the current concentration of albumin utilized. Albumin is produced from fractionated human plasma and is imported to Canada from international suppliers at a cost of approximately $22 million annually. Per Canadian Blood Services data, in the 22 to 23 fiscal year, national dollars spent on albumin for all provinces and territories, excluding Quebec, was $22 million. In Saskatchewan, during that same fiscal period of 22 to 23, our total expenditure on albumin was $1.15 million. The cost of albumin versus crystalloid solutions in Canada is as such. So currently, albumin is costed out at about $61 per 25 gram equivalents. Ringer's lactate is $1.80, and normal saline is $1.41 per liter. A recently published study evaluated the cost of resuscitation fluids internationally and reported that even after taking into account the greater volume required to achieve equally effective volume challenge, the cost of normal saline compared to albumin was 27-fold less than albumin for the same volume expansion. Besides the escalating clinical usage and cost concerns of albumin, ethical dilemmas surrounding its unnecessary utilization exist. Canada, like other developed nations, heavily relies on blood products from paid donors in the US and globally. Paid donation centers in the US often target low-income individuals, with collection centers located disproportionately in some of the country's poorest communities. There were many investigative journalism pieces like the one that's pictured here in The Atlantic that shed light on the ethical issues associated with plasma donation. What's more, the financial incentive paid to donations also poses a risk that the donor will misrepresent their eligibility. Indeed, a plasma donation center in Ohio found that 13% of donors misled clinic workers about their health for compensation. These concerns are exacerbated by the risk of adverse reaction from donation, with female donors facing higher risks than males. Turning now to the risks associated with albumin. Recent clinical trial data has begun to emerge, shedding light on the adverse effects of albumin, including the following: transfusion-associated circulatory overload or TACO, hypotension, particularly in cardiac surgery patients on ACE inhibitors, anaphylaxis for the rare patients lacking proteins like haptoglycins, sometimes resulting in fatalities, increased need for blood transfusion due to hemodilution or increased bleeding, which has been observed in cardiac surgery trials, as well as peripheral gangrene related to progressive hemodilution of natural anticoagulants, leading to thrombotic complications. And this was reported by McMaster University and published in the New England Journal of Medicine. Because of the potential benefits and risks associated with its use, a multidisciplinary international panel recently convened to develop evidence-based recommendations for the use of intravenous albumin in critical care, cardiovascular surgery, renal replacement therapy, and cirrhosis. The evidence supporting this guideline arises from a systematic review of randomized clinical trials and systematic reviews, in which multiple databases were searched from inception through November 23, 2022. The panel reviewed the data and formulated the guideline recommendations using grade methodology. The guidelines were revised after public consultation. This guideline development process was funded by the Ontario Regional Blood Coordinating Network and the International Collaboration for Transfusion Medicine Guidelines, and it was published this March. The panel made 14 recommendations regarding albumin use, of which we will focus on the ones that are most pertinent to our practice today. The crystalloid versus colloid debate of the last several decades brought albumin into the spotlight for critical care literature. This ongoing debate produced a number of large randomized controlled trials and meta-analysis use in critically ill patients that provide some of the highest quality evidence informing use in many patient populations, where the evidence is often restricted to retrospective observational data, or small prospective studies in other clinical areas. So in our first clinical setting that we're going to be looking at today, clinical setting number 1, critical ill patients. The recommendations falling out of this recent guideline is recommendation number 1. In critically ill adult patients, excluding patients with thermal injuries and acute respiratory distress syndrome, intravenous albumin is not suggested for first-line volume replacement or to increase serum albumin levels. This is a conditional recommendation, moderate certainty of evidence of effect. A systematic review from 2019 identified 55 RTCs comparing crystalloids and colloids in critical care. This review, involving over 27,000 patients, found that crystalloids were less effective than colloids in maintaining MAP, but this did not translate into any improvement in patient outcomes. There was no significant difference in fluid balance between the two groups, although crystalloid patients were administered a total higher fluid volume with a mean difference of approximately 2 liters. Importantly, mortality rates did not significantly differ between the two groups, as you can see from the chart here. The saline versus albumin fluid evaluation trial, otherwise known as the SAFE trial, conducted nearly 20 years ago, remains the largest randomized controlled trial looking at albumin versus saline for fluid resuscitation. Enrolling 6,997 ICU patients, it randomly assigned them to receive either 4% albumin or normal saline for intravascular fluid resuscitation. Despite its large size, the trial found no significant difference in mortality rates, duration of ICU or hospital stay, days of mechanical ventilation, or the need for renal replacement therapy. Interestingly, patients treated with albumin did receive more packed red blood cell transfusions compared to those in the normal saline group. Notably, a post-hoc analysis conducted in 2011 on patients with severe sepsis revealed that albumin therapy was associated with a reduced odds ratio of death, however, with the odds ratio being 0.71 with a 95% confidence interval between 0.052 and 0.97 with a P of 0.03. A 2015 systematic review evaluated the administration of albumin in critical care again. This review included 10 RCTs comparing different resuscitation fluids in trauma patients who required fluid resuscitation, and 4 RTCs in traumatic brain injury patients. Comparing albumin with crystalloids, they found a higher mortality in albumin-treated patients who had traumatic brain injuries. Notably, the SAFE trial accounted for 57% of the patients included in this systematic review. The SAFE trial subgroup analysis then found that patients with traumatic brain injuries showed a higher mortality rate, but those without traumatic brain injury did not. Additionally, fewer favorable neurological outcomes were observed at 24 months in the albumin group than in the saline group. Similarly, there were fewer favorable neural outcomes in the patients with severe traumatic brain injury in the albumin group. Hence, it is uncertain why albumin may be unsafe only in patients with traumatic brain injury compared to the wider population, and more robust studies are really needed to tease out this relationship a bit more. In a systematic review from 2020, analyzing 23 trials of over 14,000 patients, albumin was not found to offer any advantage over crystalloids in terms of mortality or acute kidney injury in the management of sepsis. A Cochrane review conducted in 2018 and involving more than 12,000 patients concluded that there was no significant difference in either 30 or 90-day mortality rates between albumin and crystalloid, nor in the need for renal replacement therapy. Similarly, a systematic review from 2014, comprising 16 trials with over 4,000 patients, found no difference in mortality rates between patients receiving crystalloids or albumin. Notably, multiple network analyses have reinforced these findings, indicating no mortality advantage associated with albumin administration in sepsis. So the overall conclusion is that these collective findings, emphasize that albumin does not demonstrate superiority over crystalloids in improving patient outcomes in sepsis. In the LBOS trial, the largest randomized trial in sepsis to date, 1,800 patients from 100 ICUs with severe sepsis were randomly assigned to receive either 20% albumin or crystalloid solution alone. In the albumin group, the largest serum albumin concentration was 30 grams per liter or more until discharge from the ICU or 28 days after randomization. During the first 7 days, the albumin group showed a higher mean arterial pressure compared to the crystalloid group with a P of 0.03 and a lower net fluid balance, although the total daily administered fluid did not differ significantly between the two groups. Importantly, there were no significant differences in 28 or 90-day mortality rates between the two groups, nor were there significant variations in other secondary outcomes. Although intravenous albumin has been shown to be safe in sepsis, studies have not conclusively demonstrated a survival benefit compared to crystalloids. Considering the considerable cost difference between albumin and crystalloids, the 2021 International Guidelines for Surviving Sepsis campaign does not recommend albumin as a first choice for fluid resuscitation in patients with sepsis or septic shock. And this is a strong recommendation. However, the guidelines suggest, with a low level of evidence, considering albumin use in patients who've received a large volume of crystalloids. This recommendation is based on evidence indicating that blood pressure at earlier and later points, higher systolic filling pressures, and lower net fluid balances with albumin. Importantly, limited data precludes specifying a cutoff value for crystalloid infusion above which albumin might be considered as part of the resuscitation, however. Our second clinical setting is cardiac or vascular surgery patients. This is recommendation 8 from the guideline. In adult patients undergoing cardiovascular surgery, intravenous albumin is not suggested for priming of the cardiovascular bypass circuit or for volume replacement. This is a conditional recommendation with moderate certainty of evidence of effect. Intravenous fluid therapy plays a critical role in the perioperative cardiac surgical care. Utilized for various purposes, including priming of the CPB circuit, volume expansion during cardiopulmonary bypass pump, and managing intraoperative and postoperative hypertension and restoring volume in bleeding patients. Traditionally, albumin was favored in cardiac surgery for its perceived advantage in maintaining hemodynamics and mitigating risks associated with positive fluid balances compared to crystalloids. Specifically, albumin is used for volume replacement due to its hemodynamic benefits. Additionally, albumin in priming helps reduce the drop in platelet count, preserve intravascular colloid oncotic pressure, and reduces perioperative weight gain and on bypass fluid balance. In North America, around 30% of perfusionists use 25% albumin for pump priming, whereas in Europe, balanced crystalloid solutions are preferred. As part of the international collaboration for transfusion medicine guideline development that we've been reviewing, researchers conducted a systematic review and meta-analysis of randomized control trials involving pediatric and adult patients undergoing cardiovascular surgery. The review identified 43 RTCs encompassing approximately 3,800 patients, which compared the use of albumin with gelatin, starches, or crystalloid solutions for various purposes during cardiopulmonary bypass. Among the trials included, mortality was assessed in 15 studies, with no significant difference observed between albumin and other solutions. Secondary outcome analysis revealed that intravenous albumin was associated with smaller fluid balances, higher mean albumin concentration, but no differences were found in the rates of kidney failure, blood loss, ICU and hospital length of stay, blood component use, or cardiac index. This is a very tiny graph, but if you can zoom in, you can see that for all of the study groups included in this study, the diamond does line up along the middle, representing the overall summary of effect, is directly on the vertical line, and the pooled estimate of risk of difference of mortality was 0. Adult patients undergoing cardiovascular surgery did not demonstrate a significantly difference in mortality when IV albumin was used for CPB priming or volume resuscitation. In this 2022 randomized, double-blind, single-center clinical trial involving 1,300 patients undergoing cardiovascular surgery, participants were randomly assigned to receive either 4% albumin solution or Ringer's acetate as a cardiopulmonary bypass prime and perioperative intravenous fluid replacement. The primary outcome was the number of patients with at least one major adverse event, being death, myocardial injury, acute heart failure, resternotomy, stroke, arrhythmia, bleeding, infection, or acute kidney injury. Notably, the combined evidence of major perioperative and post-operative complication was 37% in the albumin group and 33.8% in the Ringer's acetate group, with no statistically significant differences observed between the two groups. The results of this trial indicate that treatment with 4% albumin solution for priming and perioperative intravenous volume replacement compared with Ringer's did not significantly reduce the risk of adverse effects over the following 90 days among patients undergoing on-pump cardiovascular surgery. Indeed, while myocardial injury incidence was lower in the albumin group, this difference was primarily reflected in laboratory results, specifically a reduced rate of troponin elevation above the upper limit of normal, without translating into any differences in actual cardiovascular events. Conversely, incidence of bleeding, resternotomy, and infection were significantly higher in the albumin group. Additionally, the albumin group exhibited a significantly lower total fluid balance, yet experienced higher rates of chest tube drainage, as well as the need for red blood cell and platelet administration compared to the Ringer's acetate group. Our third clinical setting is non-cardiac surgery patients. In this area, there really is a lack of evidence-based guidelines for perioperative albumin and a paucity of data exploring important clinical outcomes associated with its use among non-cardiac surgery patients. There really is a lack of methodologically robust, adequately powered trials to evaluate the efficacy of intravenous albumin in the setting, and they are clearly needed. This study was conducted across 54 US hospitals by the Multi-Center Perioperative Outcomes Group and was published earlier at the end of last year in October. This marks the first large-scale investigation into the use of intraoperative albumin during non-cardiac surgery and its post-operative impacts. Spanning from January 2014 to June 2020, The study included adult patients undergoing major non-cardiac surgery under general anesthetic. The primary objective was to examine albumin administration rates, with the secondary endpoint encompassing acute kidney injury, net positive fluid balance, pulmonary complications, and 30-day mortality. Analysis involved comparing outcomes between cases with and without albumin exposure within a propensity scored matched cohort. Among the approximately 600,000 cases meeting inclusion criteria, 15.3 involved intraoperative albumin. Most cases, or 96.8%, use iso-onconic 5% albumin solution, with the remainder using the hyper-onconic solution. Observed significant inter-institutional variation in patterns of use among the U.S. medical centers, with use really being higher in the more academic centers that were aligned with universities. And they did really comment on the differences in practice patterns and administration patterns being institutionally driven. Patients receiving intraoperative albumin had higher ASA scores and received larger crystalloid volumes, experienced greater blood loss, and required more vasopressors. A mixed effect model in the PS matching outcome cohort showed significant associations between albumin use and measured outcomes, including severe AKI, positive fluid balance, and pulmonary complications, as well as 30-day all-cause mortality. This small randomized controlled trial comprising 40 patients, which was published in 2016, looking at the impact of albumin versus Ringer's lactate on coagulation in blood loss in cystectomy, aimed to investigate the impact of administering 5% of albumin or Ringer's lactate on coagulation competence and subsequent blood loss during cystectomy for bladder cancer. The study found that by TAG evaluation, coagulation competence, albumin administration significantly affected clot growth and strength compared to Ringer's lactate. Significant differences were observed in plasma coagulation variables between the two groups, with APTT being significantly decreased in the Ringer's lactate group and INR significantly increased in the albumin group. Despite these alterations, however, in coagulation patterns induced by albumin, no clinical impact was observed, as evidenced by the absence of differences in blood loss, need for transfusion, incidence of postoperative complications, or hospital length of stay between the two groups. So albumin seems to impair hemostasis in a concentration-dependent manner. In cervical clinical trials, albumin impaired hemostasis in thromboelastometry, or TEG, because albumin remains in the circulation for a longer period than crystalloid. Hemodilation of coagulation factors may be partially explain the impaired hemostasis with albumin administration. Albumin may also impair platelet aggregation. Albumin inactivated platelet activating factors, prostaglandin H2 and thromboxane A, and induces macrophage nitric oxide production. In this feasibility study, 23 cystectomy patients were administered 20% albumin alongside lactated Ringer solution for the management of blood loss. This study was completed in 2021. Blood samples were collected over 300 minutes to assess blood volume expansion using regression equations and under the area under the volume curve method. The average blood loss was approximately 974 mL. Researchers observed a strong correlation between blood loss and the combined effect of Ringer's lactate and 20% albumin solution. They found that for each millimeter of lactated Ringer solution infused, plasma volume expanded by 0.38 mL on average, whereas for 20% albumin, it expanded by 1.4 mils per mil of albumin administered over a 5-hour period. Blood volume expansion with 20% albumin was therefore 1.9 to 2.2 times the infused volume during surgery, associated with approximately 1,000 mils of bleeding. Limitations of the study include assumptions about predicting blood volume using regression equations, the inclusion of elective patients who may not typically require volume resuscitation, and a lack of measured clinical outcomes, as well as the short follow-up duration that was limited to the 300 minutes of the trial. Recent studies highlighting the potential risks of acute kidney injury have been published with the use of hyperoncodic albumin. A cohort study involving 984 post-operative cardiac surgery patients revealed a dose-dependent increase in AKI with hyperoncodic albumin administration. Similarly, a retrospective cohort involving 11,500 post-operative shock patients, primarily after cardiac surgery, found a higher AKI risk with hyperoncodic albumin exposure. However, it's important to note that these are observational studies assessing hyperoncodic albumin and AKI, and therefore may be limited by potential residual confounding factors. In contrast, a randomized controlled trial of 220 off-pump coronary artery bypass surgery patients demonstrated that preoperative 20% hyperoncodic albumin significantly reduced postoperative AKI compared to normal saline administration in patients with low albumin levels. So the role of albumin in clinical practice. Pharmacokinetic studies suggest faster and prolonged plasma expansion with albumin compared to crystalloids, but no significant improvement in long-term clinical outcomes. Some studies demonstrated improved MAP and decreased fluid balance with albumin, but again, no corresponding improvement in patient outcomes was noted in these studies. Despite the frequent use and high costs, minimal data supports routine intravenous albumin use. Few evidence-based indications for intravenous albumin exist in clinical practice, and there are even fewer for improving patient outcomes. In a 2023 podcast by Dr. Daniel Nevin, an intensivist based in Calgary, he discussed the concept of low-value care associated with albumin fluid resuscitation in critical care settings. This concept was initially proposed in a 2017 paper by Ashog and colleagues, and this was published in the Lancet. According to the definition, low-value care refers to interventions that offer little to no benefit to the patient, where potential harm outweighs benefit, or where the added costs do not justify the benefits. Albumin administration in critical care and perioperative care likely fall into this definition. Reducing low-value care is crucial for several reasons. Considering patient care, it's essential to acknowledge that all therapeutic and diagnostic interventions come with inherent risks. As healthcare providers, our foremost responsibility is to ensure that the benefits of any intervention clearly outweigh these risks. Patients rightly fully expect us to prioritize interventions that offer substantial benefits while minimizing potential harm. Consequently, interventions that offer little or no benefit while carrying risks are understandably less desirable from a patient's perspective. Shifting our focus to the broader healthcare system, it's crucial to recognize that every intervention incurs costs, and healthcare resources are finite. Continuing to use interventions that do not unequivocally improve patient outcomes not only results in increased healthcare expenditures, but also fails to enhance overall healthcare quality, or patient quality of life. This becomes particularly pertinent in the context of albumin administration, where the global demand for albumin is on the rise, consequently driving up costs. Moreover, the procurement of albumin often involves the exploitation of low-income donors in the US and developing nations, raising significant ethical and social concerns. Furthermore, We must also consider the environmental impacts of healthcare provision. Anesthesia, with its extensive use of gases, drugs, equipment, and packaging, contributes significantly to greenhouse gas emissions. While certain aspects of this environmental footprint are unavoidable, it's essential to mitigate our impact where possible. This includes reducing the consumption of plastics and non-reusable materials associated with unnecessary interventions. By doing so, we can play our part in promoting environmental sustainability and contributing to a healthier planet for future generations. Thank you. I'll turn the stage over to Dr. Oksana Prokopchuk-Gauk.
So thank you very much to Gemma for a very well-presented summary of the literature. The detail provided was truly reflective of the evidence we have. And I'm sure many of you are thinking about, well, what about this post-operative situation where my patient is hypotensive? Or what about this situation where the patient's not in ICU? I think what we know is what we know in terms of the evidence that's presented, but I do believe there is still a lot of area yet to be explored as it relates to albumin utilization in various settings. So I was asked to just discuss some of the national, provincial, and local albumin utilization data. So this slide is as of April 2024 and simply demonstrates that over the last 5 years, albumin utilization nationally has been fairly stable. So the units here are a little bit different. It's a total 25 gram units per 1,000 population. So this is per capita data. In terms of 25 gram units, that would be equivalent to one vial of 100 ml 25% albumin or one vial of 5%, 500 ml albumin. So all of that data is combined here, just to sort of demonstrate that national utilization really hasn't changed a ton over the last 5 years. Next slide. However, where we do see some discrepancy is when we separate out the provincial data. So this is data from Canadian Blood Services that was available to us as of April of 2022. So Dr. Ryan Lett, who's one of your anesthesiology colleagues and here on the line today, and I are representatives at the National Advisory Committee on Blood and Blood Products table, where we discuss various aspects of transfusion appropriateness, inventory allocation, best practices in Canada, and we always review the Canadian Blood Services blood component and plasma protein product trends at our meetings to see how things are going in terms of, are we really doing what we're supposed to be doing in terms of making sure our public healthcare dollars are being spent appropriately. And in 2022, the table, sort of attendees at the table looked at Ryan and I and said, what's going on in Saskatchewan related to albumin? Because your use is the highest and it's climbing. And so Ryan and I looked at each other and said, we don't know. We don't know what's happening, but we need to find out. So we said we would do that. So the dotted blue line is, again, that national average of albumin utilization. You can see Saskatchewan is much above that. Next slide. So we took a look at the literature and saw that there was an audit from a large center in Ontario that identified that albumin use is inappropriate in approximately 50% of patients. So this was published back in 2020. And so Ryan and I thought, well, maybe we are falling into the same category with the majority of our use being inappropriate, because otherwise, why would we be such an outlier? So we applied for Dean's Project funding and were granted support for summer research students who completed work in Saskatoon and Regina. And so we are very, very grateful to our students, Madeline Owens from Saskatoon and Lindsay Zimmerman from Regina, who worked with us last summer to collect chart data to understand what's been happening in Saskatchewan in terms of our albumin utilization. Next slide. So we hypothesized that at least 50% of the albumin administered to Saskatchewan patient was for inappropriate indications. We thought, well, we must be at least parallel to what the Ontario findings are reporting. So our students completed a retrospective chart audit of albumin utilization in Saskatoon and Regina between January 1st and February 28th, 2023. And so this was a detailed manual chart review to collect the data. So they spent hours combing through charts to make sure to accurately capture patient demographics, indication for albumin transfusion, albumin product concentration and dose, and any transfusion adverse reactions encountered. The University of Saskatchewan Clinical Trials Research Unit helped with some of the data analysis as well, so we're grateful for their support. So given the time of our study, with the audit being completed last summer, this was before the ICTMG albumin utilization guidelines were published. The teams had anticipated that those guidelines would be published last year, but just because of additional requirements by editors of journals and what have you, the ICTMG group publication was delayed to ensure that all reviewer requirements were satisfied for that publication. So the appropriate versus inappropriate criteria were developed based on the summary of indications based on where there is or isn't evidence, as summarized in Bloody Easy 5.1. So that's where we really got this list in terms of what was appropriate versus inappropriate. And then Maddie and Lindsay judged appropriate versus inappropriate indications based on the predetermined appropriateness criteria. Next slide. So this slide just summarizes the demographics of patients that were included in the chart review. You'll see that there were just over 400 patients that were audited in the 2-month study period, a few more in Saskatoon than in Regina. And then with those patients, what was adjudicated was the number of albumin orders in terms of appropriateness. So you'll see that for each patient that was enrolled or included in the study, each of those patients had about 3 albumin orders, and an order would be an albumin dose within a 24-hour period. So most of these patients didn't just have 1 albumin infusion, it was more than that. Next slide. So in addition to collecting data separately for Saskatoon and Regina sites, the findings of our students were compared. They got together and were able to look at the data side by side to see what's happening between our 2 centers. So in terms of 5% albumin, a majority of the dosing was given to outpatients, and a majority was given within the ICU or on the wards. In terms of appropriateness based on predetermined criteria, you'll see that when we compare both sites, Saskatoon seems to have a significantly higher rate of inappropriate albumin administration as compared to Regina. Overall, the inappropriateness was adjudicated to be 6.1%. Next slide. So once again, in terms of comparing the 2 sites, the asterisk is indicating which indications are considered appropriate. So there was a significantly larger proportion of patients in Regina who were using the 5% albumin for apheresis, which is actually the only true evidence-based indication. Stem cell collection and drug preparation are certainly on label and recognized as appropriate for this use, but it's really a minority of cases. In terms of paracentesis, hypotension, management of hemorrhage, sepsis, fluid overload, various percentages seen. You'll see that in Saskatoon, there was a trend to use albumin, 5% albumin for management of hypotension much more commonly than in Regina. So that was the one area of difference. And high users of albumin were predominantly internists as well as nephrologists. So it's interesting that this audit identified such a significant discrepancy between our 2 sites as it relates to 5% albumin. Next slide. From a 25% albumin perspective, the results are a little bit more balanced, but ultimately identified that we're equally poor in terms of our appropriateness of use. So again, most of the 25% albumin was administered in the inpatient setting in this case. Next slide. Once again, the indications with an asterisk are denoted as appropriate indications based on the evidence and documents used at the time of the audit. So we're seeing fairly balanced rates of use between the two sites, with the exception of Regina, that's using more albumin in the setting of post-paracentesis administration, which is evidence-based. In terms of cardiac surgery, this was another interesting difference where we did see that there was a significantly larger proportion of use of 25% albumin in Saskatoon versus Regina. We do know, and perhaps Ryan can speak a little bit more about this, we do know that in Saskatoon, there is use of the albumin of 25% albumin to prime pumps, whereas in Regina, this is less so the case. Okay, next slide. From an adverse transfusion reaction perspective, there's only one reported during the audit, and it was a minor reaction. Interestingly, this patient was also receiving packed red blood cell. Death within 24 hours of infusion was documented in association with 8 orders of 5% albumin and 28 orders of 25% albumin. And these were predominantly noted to be in the setting of what would be considered inappropriate. Now, this statement is being made as an observation. We're not implying causation here, but it's simply an observation in the context of this retrospective audit. In general, adverse transfusion reactions are underreported, so the rates may actually be higher than what we had identified within the study. Next slide. The good news is with the audit having been initiated and a lot of conversation happening about, well, why are we using albumin? What is the purpose? And are we doing our patients benefit by giving them albumin, or are we potentially increasing the risk of harm? We have started to see a downward trend in our albumin utilization throughout the last year, which is really good. However, we still have room to do much better. And I think that Gemma's slides are certainly very thought-provoking in terms of how are we as a system using albumin in Saskatchewan? And is this truly to the benefit of our patients, or are we as healthcare providers giving albumin to try and improve numbers to make ourselves as healthcare providers feel better? Certainly, there are areas where the evidence is convincing, especially the randomized control data that's high quality. But those populations that were involved in those studies, certainly those results aren't translatable to every patient that we currently treat in hospital. And so in the areas where we're seeing gaps, I think we still don't really know what the right thing to do is for our patients in certain situations. Next slide. So in summary, our audit confirms that the majority of albumin transfused in our province is for inappropriate indication. This audit identifies that the development and implementation of strategies to improve albumin use appropriateness are required to reduce albumin utilization and patient exposure to a potentially unnecessary treatment. And again, I think that consideration of appropriateness indications, specifically those where there's high quality evidence, really challenge us to ensure that we're aligning with guideline recommendations within clinical practice. So my challenge to everyone is before they're administering albumin to really consider, is this product being given for a best practice indication, or is it something that I've just done forever and that I have comfort with doing? We do recognize that Saskatchewan spent $1.15 million in 2022-2023 on albumin. So thinking that our inappropriateness is somewhere in the neighborhood of 70%, there's as high as $750,000 per year that could be saved for the healthcare system if we merely improve our appropriateness of use. And that's not just to get to the national average of albumin utilization. We've identified that albumin use is inappropriate in many settings, but certainly just driving down that cost, even some, will be helpful overall to the system itself and hopefully improve patient outcomes, because albumin administration certainly isn't benign, as has been demonstrated. So we really need to be careful to make sure that we're doing the best for our patients and not exposing them to undue risk with this blood product.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.